Welcome, Dr. James. Our presentation is titled Heart Healthy Hormones by Nicole Borowski and myself, Cindi Wiggins. This is our agenda and what we are going to be talking about today. We will focus on menopausal hormone therapy and cardiovascular health. Menopause is a natural part of aging. It's defined as the absence of menstrual periods for 12 consecutive months. This is the result of decreasing amounts of estrogen and marking the end of the reproductive era. This typically occurs between the ages of 45 and 55. Prior to menopause, the perimenopausal phase, also known as menopause transition, is marked by irregular periods and symptoms ranging from hot flashes, sleep disturbances, irritability, and many, many more. These symptoms can last for up to 10 years for some. During this time, women may show signs of increased blood glucose and cholesterol levels, increased blood pressure, and decreased bone density. The use of hormonal therapies can significantly decrease or alleviate symptoms, especially if started early in the perimenopausal stage. These range from various types of estrogen and progesterone only to combination therapies in multiple forms. Oral, transdermal, and vaginal suppositories being the most common. Unfortunately, hormone therapy requires a prescription from a healthcare provider. This is a barrier for many women around the world who don't have access to healthcare or cannot afford it. Many women don't utilize hormone therapies even with access. There are many reasons, but stigma, embarrassment, and lack of trust in the healthcare system are some examples. Cultural beliefs also play a significant role for many women who believe treatment is just unnecessary. This led us to our question: is there a link between menopausal symptoms and hormonal therapies or lack thereof and chronic illness, specifically cardiovascular disease? Our literature search began in 2025 in September and used 3 databases: PubMed, Embase, and Google Scholar. We only considered sources from peer-reviewed journals, reports, and national newspapers, all articles having been published within the last 5 years. We collectively obtained 60 articles and narrowed the relevant articles to 33 based on our decided focus. Perspectives included menopausal symptoms, the benefits and risks of hormonal therapy, historical clinical practice, access disparities, and various treatment strategies. Our focused area was determined based on these overlapping themes. Our limitations for the search process included search and theme discrepancy, as well as personal bias of the literature. Menopause is marked by accelerated cardiometabolic dysfunction, vasomotor, sleep, and mood that drive higher atherosclerotic cardiovascular disease risk. This results from the buildup of plaque in the arteries. We found that hormone replacement therapy is most effective in women less than 60 years of age and within 10 years of initial menopausal symptoms. Timing, age formulations, dose, route, and comorbidities determine hormone therapy benefits and risks. Early initiation is recommended, while older initiators, especially in their 70s, show increased cardiovascular disease risk. Non-oral, transdermal, and low-dose routes are safer with less thrombotic risk, while oral high-dose combined formulations and certain progestins carry higher thrombotic and mortality risks. Compounded and bioidentical formulas are not recommended. Hormone therapy remains the most effective treatment for vasomotor symptoms of menopause, but is not recommended for primary or secondary prevention. Based on our main findings, this chart demonstrates the most critical factors of safer hormone therapy use: time since menopause began, the formula used, delivery route, and duration of use. Each of these has significant implications on the health of the woman using hormone therapy and may lead to benefits against cardiovascular disease, or unfortunately, can bring about a higher risk of cardiovascular disease and other fatal conditions. This is why it's imperative to ensure that a hormone therapy regimen follow an evidence-based, sound decision-making process accompanied by the clinician and a broader support system. Overall, we see that early normative menopause transition with estrogen transdermal low-dose formulas for 1 to 5 years with reassessment is best associated with treatment success and decreased cardiovascular risk.
These 6 themes are the most common in the sources, being used as the guiding principles for recommended hormone replacement therapy use. They span from the individual level to clinical practice and even systemic interventions, and work together as the foundation needed for evidence-based approaches. The amount of times each theory was used within our matrix is seen in the replication column. We see that the 3 most mentioned refer to when a woman begins hormone therapy, her overall risk assessment considering personal health, and finally the natural process of menopause that emphasizes a holistic approach to overall health. The cost burden of menopause is significant. The Mayo Clinic estimates losses of $1.8 billion per year in the US. Women make up 47% of the workforce and are at their peak earning potential when menopause transition begins. Many experience severe symptoms affecting work life, causing production loss, increased sick leave, and even career stagnation. Some choose to take early retirement, decrease amount of days working, or even change jobs altogether. This has significant impacts on their financial status, retirement, and quality of life. Women are driving the menopause management market today, which is worth $600 billion. Women are looking for alternatives to traditional hormone therapies of the past, and they are demanding something better and safer. The economic cost of menopause and the link to cardiovascular disease is hard to determine. Research focuses more on men, although women face poorer outcomes. Patient costs related to cardiovascular disease are twice the cost of those without. A Canadian study found that while hospital admissions, emergency services, outpatient care, and medications make up the significant portion of the costs, social costs like residential and home care, informal costs like unpaid care by family and friends, or even production losses from disability and death are also key factors. In 2019, the estimated cost burden of cardiovascular disease in the US was $407 billion, and in Europe it was $326 billion. Technology has come a long way in empowering female healthcare. The development of phone apps and websites such as Let's Talk Menopause and Balance offer the ability to explore non-prescription methods of treatment and connect with other women. Wearables provide health insights by tracking metrics from exercise to sleep and even menstrual cycles. These technologies are raising patient engagement to new heights, but a big concern is the lack of access for all. Every time a new piece of technology is released, the equity gap grows. Another concern is privacy about our personal data. This leads to concerns that insurance companies may use our data to deny coverage or treatment. There is a high global menopausal symptom prevalence with underuse of evidence-based therapies due to fear and misinformation. Public health must promote education and research to ensure evidence-based practices. Research needs to focus on longer trials of new therapy formulas and routes. Studies in diverse populations and evaluations of long-term safety and discontinuation strategies are also needed. App-based interventions are also required to best instruct future public health and clinical practice. Equitable access to hormone therapy treatments focuses on equity gaps and is needed as well. It includes racial, socioeconomic, and geographic disparities, which all affect symptom burden, health access, and treatment rates. The health information must also be culturally tailored in order to be sustainable. Through advocacy, aligned policies are needed to reduce misinformation and inconsistent practice. Clinically, there is a need for better physician training, standardized assessment tools, and clear discontinuation guidance. Patient education is also needed to overcome fear of hormone therapy use that has been debunked. Clinicians should use advised screening and assessment tools. They should also use yearly patient-centered shared decision-making perspectives, ensuring timing is of essence when considering personal health history, preferences, and risk benefits of the most appropriate therapy regimen. Harmonized care pathways and integration of menopause prevention frameworks is also recommended. Overall, clinicians should use individualized treatments and empower women to take active roles in healthcare discussions and health system planning. Menopause apps and digital symptom tracking can improve patient health knowledge, communication with clinicians, and may reduce menopausal symptoms. Lastly, more clinician advocacy for healthcare access and equity is needed. Our conceptual frameworks model the theories that best support future actions for menopausal hormonal therapy. On the right side, we have the theories in a flowchart showing how they combine to best support appropriate therapy decisions from a personal to clinical and systemic levels. Our bubble diagram on the left illustrates how each of the female healthcare is nested within a broader sphere of influence, each of which addresses menopausal health, access to care, and cardiovascular management. Thank you so much for listening to our presentation. This is the end of our slides. The following are references used to make these slides possible.